Hi, this is Jeff Klein, editor of RadioGraphics. And today I'm pleased to have with us Dr. Vinay Prabhu from the Department of Radiology at the New York University Langone Medical Center in New York, who is the author of one of our featured papers in the July 2019 issue of RadioGraphics. And his paper is entitled Preoperative Imaging for Facial Transplantation, a Guide for Radiologists. Dr. Prabhu, welcome to our podcast.
Thank you for having me.
So, Vinay, your paper addresses facial transplantation, which most of our listeners will probably have heard of, at least from the lay press, but they've likely had no experience with it as radiologists. So let me ask, how did you and your group come about writing about this particular topic? Does your medical center have a significant craniomaxillofacial plastic surgery service that led to these transplantations? And the related imaging, obviously. Any sense for how many institutions in the US or worldwide are doing these procedures?
Those are all really great questions. We first became involved in imaging for facial transplantation back in 2013 at NYU. This was when Dr. Eduardo Rodriguez, who is the senior author on the current paper, was named the chairman at NYU's Department of Plastic Surgery. And prior to coming to our hospital, he already distinguished himself as a leader in the field, completing a landmark 36-hour facial transplant at the University of Maryland. That's sort of part of the reason he was recruited. And it was the most extensive transplant to date. After coming to NYU, he still continues to push the envelope in terms of evaluating the most challenging patients from all over the world, recipients and donors. And thus, we really needed to standardize our radiology protocol to assist them, since these are very complex surgeries. These are things we hadn't seen before. And since then, we've kind of become an integral part of the multidisciplinary team, beginning our involvement immediately after donor selection. And it's kind of a nice thing to see how we can add value, going forward. And to answer your question about how many institutions are doing this, my general sense is that about 10 countries around the world, full or partial transplants of the face have been performed. And I think it's about 5 academic centers in the US have at least done or performed them. I don't know how many are starting up right now. And I only anticipate this to grow as they standardize protocols and as the leaders in the field continue to train young surgeons and surgeons who are interested in this this procedure that greatly enhances quality of life. I think for these patients, at least so far I've seen.
Terrific. Well, thanks for that. So, your article begins by briefly describing 2 index cases that illustrate the clinical scenarios surrounding facial transplantation. The paper then delves into how donors and recipient candidates are imaged preoperatively, which you summarize nicely in Table 1. Can you take us through the preoperative imaging protocol that you employ? And we'll show Table 1 here for our viewers as you describe it.
Sure. Yes. Table 1 details our CT protocol, which aims to maximize the clinical information that we can get for the surgeon in a single session. And we do get a lot of information. So just to kind of briefly give an overview of the table, all of our scans are performed from C6 to the cranial vertex, and this provides complete information from the entire head and neck on all phases, because these patients can sometimes have very extensive cranial injuries, facial injuries that potentially can change operative procedures. So first, you'll see at the top of the chart, we obtain a standard non-contrast CT. This is used not only for computerized surgical planning that'll help guide the surgeon's osteotomies during the transplant, but it also is used for creation of subtraction images in situations where dual energy is either not available or insufficient, or they want standard non-contrast in order to get a true subtraction. Second, after we perform a control scan and a test bolus, we perform a CT angiogram with 60 cc's of contrast. This is mainly used to provide a detailed arterial anatomy, but it not only gives us the assessment of the branching pattern, but also the relative location of arteries in relation to other vital anatomic structures that would be relevant to surgical approach. For example, the thickness of the subcutaneous fat in patients who've had large defects, overlapping muscles, underlying bones, prior surgical material that might get in the way or might ruin the surgical technique. Third, we take a delayed set of images through the head and neck again, and it's a delayed venogram. This provides not only vascular anatomy of the veins, but also gives us more information about adjacent structures. It also provides us with information on collateral pathways that have formed that may not be evident on the initial angiogram. And these are very common in patients who have had trauma or prior surgeries to try to fix their facial defects. All of this information is essential for the surgeons to know when planning their dissection and the vascular and osseous anastomoses. And lastly, you'll see at the bottom of the chart, we do a lot of post-processing steps, and I think these are really helpful for visual aids during these sometimes surgeries that take longer than a day. They get into stuff that they don't realize, and these images definitely help them. And the images are also sent for, like I said, for the computerized surgical planning to an offsite company that helps to make them.
So regarding computerized surgical planning, or CSP, you describe and illustrate the use of the craniofacial CT of both the donor and recipient, and how the osseous structures are aligned to aid in identifying the appropriate osteotomy sites that are then 3D printed for intraoperative use. Can we look at figure 2, which shows an example of how this is done in patient number 2 and donor number 2 in the paper?
Sure. Before I delve into the images, it's important for us to understand, and I want to explain why the osteotomies are created in facial transplants. And this is something that I didn't understand early on, but it becomes pretty obvious. So the facial transplant not only consists of skin, subcutaneous fat, which is what we see on the outside, but it also has an extensive array of underlying fascia and musculature. And these things attach very tightly to the underlying bone. And because of this, the graft is best suited when the bone is transplanted along with these structures. And to aid in this process, you can't just take off any piece of bone and put it on there. You need detailed, kind of identical sections of bone in the donor and the recipient. So computerized surgical planning, which is demonstrated in this figure, involves the use of CT images to generate osteotomy cutting guides with near identical cutting lines for the surgeon to make on the donor and recipient, so that the donor bone, which is attached to obviously the facial transplant, can be attached to the recipient bone, which will receive the facial transplant. This not only facilitates the healing process, it optimizes the facial structure in patients with severe soft tissue defects, and it prevents future graftosis or drooping. So let's get into the figures real quick. Figure 2A shows patient 2's facial skeleton, which is largely intact, which is not always the case. The reason why is because this gentleman unfortunately had severe thermal burns suffered in the line of duty. He was a volunteer firefighter, so a lot of his facial structures, the osseous structures, were intact. Figure 2B will show his donor skull, which also is relatively intact, aside from a right terional craniotomy flap that was performed earlier in his hospital course in an unsuccessful attempt to treat his traumatic brain injury, which is why he became a donor ultimately. Now, figure 2C shows a few colors in there, so I want to explain what those are. So the personalized cutting guide is shown in pink, which was created by an outside vendor that I described before. It is placed on patient 2's face to aid the surgeon in removal of the green fragments of bone, and they're shown in green. Those are taken off. Figure 2D shows a similar guide that's put on the donor's face that then is used to remove the yellow pieces of bone that are removed en bloc with the face from the donor. Figure 2E then shows the final product, which is patient 2's native facial skeleton, which is shown in white, with the yellow bone fragments from the donor attached with donor 2's face, which is obviously not included on the images, so that we can see how the osseous structures interact. And as I described earlier, to summarize, the bone fragments attached are really to kind of stabilize the whole transplant and kind of keep it in place.
Terrific. So the article then discusses the use of angiography to assess the vascular anatomy, and you list the essential findings that the angiographer needs to report, as you've listed in Table 2, which we'll put up for our viewers now. Figure 3 shows how important the angiographic detail is for patient number 1 regarding preservation of blood flow to the tongue. Can we review figure 3A and 3B here and sort of talk through what the issues are?
Sure. Figure 3 kind of nicely illustrates a case-based example of how radiologists can add value to the surgical plan. by providing high spatial and temporal imaging and detailed description of the vascular anatomy. So just to go through each individual portion of the figure. So figure 3A shows a lateral digital subtraction angiogram of the left external carotid artery in patient 1, who suffered an extensive ballistic injury. The first thing you'll notice is the extensive surgical clip and surgical material that's from multiple prior surgeries. He had many prior surgeries in order to fix his facial defects piecemeal. And this made it a challenging patient, not only from an imaging, but also from a surgical standpoint. And if you pay special attention to figure 3A, you'll notice that the angiographer was unable to demonstrate a lingual artery on the left side. This should normally run anteriorly towards the tongue in the region of where all the clip artifact is. However, in figure 3B, which is an injection of the contralateral side at the same level, on the right, you'll see that the right external carotid artery provides an unusually large tortuous vessel to this region, which is denoted by the arrowheads. And then that crosses to the contralateral side, denoted by the arrow. This was extremely important for the surgeon to know, as he took extra special care during the surgery to find and preserve the right lingual artery, the origin of it, especially during his dissection. During his dissection on the right. In other patients, losing one lingual artery might not be critical, as the contralateral flow would be preserved. But in this patient, losing the right lingual artery would probably result in tongue necrosis, and that would be a very bad outcome.
Right. Thank you for that. So, you detail the importance of digital subtraction angiography and how delineation of the small vascular structures is crucial, as we just saw in figure 3. Figure 4 shows the donor and recipient, which is patient number 2, angiograms, and how this information impacted where vessels were ligated and anastomosed between the donor and the recipient. Can we go through this figure and have you describe the findings and how they impacted the surgical procedure?
Sure. So this is just another example of how we can demonstrate our value, and I think the detailed vascular anatomy, an understanding of the normal and also the abnormals is very important. So in this patient, patient 2, just to give you a background, a portion of donor 2's posterior scalp was planned to be transplanted along with the face. And this is because the patient 2, as we described, had very extensive thermal burns from a work-related injury. Therefore, it was very important to ensure adequate blood flow to the transplanted scalp. And that's usually through, especially the posterior aspect, through the occipital artery, the blood flow through that artery. Prior attempts at outside transplants that are in a different country had actually resulted in graft necrosis in these areas because the occipital artery supply was not, the theory is that maybe it wasn't paid attention to as much. And so this was something that Dr. Rodriguez wanted to pay special attention to in this patient particularly. So just to walk through the figure and sort of show how we added value, figure 4A shows that in this patient, on patient 2, on his left side, there is a common origin of the left occipital artery, which is shown by the arrowhead, and the left facial artery, which is shown by the arrow. And these are both very, very close to the origin of the left external carotid artery. As a result, the anastomosis on this side had to be performed above this level, above the level of the facial and occipital origin, so as to not disturb the native branches and allow blood flow through them. On the contrary, figure 4B shows that on patient 2's right side, the right occipital artery, which is also again denoted by the arrowhead, originates a full 4 centimeters distal to the right facial artery, which is shown by the arrow. And both originate greater than 1 centimeter above the external carotid artery origin, which allows for an easier anastomosis with the external carotid artery trunk proximal to these branches, which was not able to be done on the other side. Figure 4C and 4D show the donor angiograms with the occipital arteries, also shown by the arrows. On both sides, you'll see that they originate pretty high, and the surgeon was able to ligate just above the carotid bifurcation in the donors, since he had a long external carotid artery to work with on both sides.
Terrific. So Vinay, the final section discusses the role of CT angiography in the pre-surgical planning for facial transplantation. You stress the utility of associating the vascular anatomy with soft tissue landmarks. So in this vein, let's review figure 5, which shows the CT angiogram of patient number 1, whose digital subtraction angiogram we saw in figure 3. Can you take us through the CT angiographic findings here that are demonstrated in figure 5?
Sure. So figure 5 demonstrates the corresponding CTA of a finding we touched on earlier regarding the lingual artery supply in patient 1. I can kind of explain how it maybe adds additional value to the DSA. So figure 5A is a volume reconstruction from the CTA, which shows a common origin of the right facial and lingual artery, a variant which was important for the surgeon to know going into the operating room. Figure B shows what we were describing before. So it's an axial maximal intensity projection, which demonstrates a tortuous and enlarged right lingual artery, which is denoted by the arrow. The CT also nicely demonstrates that at the expected origin of the left lingual artery, there are many clips without filling of this artery's origin. Lastly, figure 5C shows that there are small vessels in the left lingual artery territory, which fill likely by collateral flow from the right lingual artery. The re-demonstration of this finding that was seen initially on DSA, in addition to the demonstration of an atretic, non-opacifying left lingual artery origin at the expected location, in close proximity to surgical clips, which it wasn't totally easy to see that the surgical clips are right next to the vessel. They were kind of just messing with the subtraction on the DSA. This aided the surgeon to be a little more confident regarding the lack of any left lingual artery supply. We explicitly need to spend extra time dissecting out the right lingual artery origin in order to avoid tongue necrosis. And CT is particularly useful in this respect, demonstrating with ease the relative position of both opacified and non-opacified structures and their orientation to one another. So we might be able to see surgical clips that were done from prior surgeries, but we might not be able to see flaps on the DSA. We might not be able to see, fat plugs that were put in to kind of replace skin defects or areas where they were trying to reconstruct the face. So Dr. Rodriguez finds both of these techniques very complementary to one another, and it's just a little more visually and visuospatially orienting in terms of looking at the CT as opposed to the DSA, which is mainly just a vascular evaluation.
Absolutely. Well, Dr. Prabhu, I want to thank you for taking the time today to discuss your paper on the preoperative imaging of facial transplantation, which can be found in the current July 2019 issue of RadioGraphics. Vinay, thanks so much for your time today. Appreciate it.
Thanks for having me. It was a pleasure.